here to present that phase 3 clinical study of the Ciplas, sir. The efficacy and safety of Ciplas biosimilar ranibizumab versus innovator ranibizumab for patients with the wet age-related macular degeneration. So the age-related macular degeneration is the leading cause of irreversible blindness among age group of 50 years and above. And this neovascular form of the disease is characterized by the choroidal neovascularization, that is abnormal growth and new blood vessels under or within the macula. And it is classified as classic occult angiographic patterns, which was associated with various degrees of aggressiveness of disease, vision loss, and response to various treatment options. The VEGF endothelial growth factor A is a diffusible cytokine, promotes angiogenesis and vascular permeability. The VEGF-A binds its receptors VEGF-R1 and VEGF-R2 on the surface of endothelial cells. This binding leads to the endothelial cell proliferation, vascularization, neovascularization, and vascular leakage, which contribute to the progress of the neovascular form of age-related macular degeneration. So ranibizumab, it's a monoclonal antibody fragment targeted against human vascular endothelial growth factor A. This binds with high affinity to the VEGF-A isomers and reduces endothelial cell proliferation, vascular leakage, and new blood vessel formation. So the safety and efficacy of ranibizumab for treatment of neovascular age-related macular degeneration has been approved by multiple clinical studies. So the present study was taken up to use biosimilar ranibizumab developed in India, that is from the Reliance Group, in treatment of neovascular wet age-related macular degeneration. So the study is prospective, multi-center, randomized, double-blind, two-arm, parallel group, active control, comparative clinical study to evaluate efficacy and safety of Ciplas ranibizumab biosimilar versus Lucentis in patients with neovascular age-related macular degeneration. The aim of the study is to evaluate efficacy and safety of ranibizumab biosimilar versus Lucentis in patients with neovascular age-related macular degeneration. The study period was between July 2018 and November 2019. There were 16 centers, study centers were included across India. These are the list of the study centers all over India. The objective of the study, that is primary objective, this is to compare efficacy of intravitreal injections of ranibizumab biosimilar or Lucentis in preventing vision loss as determined by the proportion of patients who lost fewer than 15 letters in visual acuity at week 16 compared with the baseline. And a secondary objective is to evaluate other efficacy parameters, immunogenicity, safety, and tolerability of ranibizumab biosimilar versus Lucentis up to week 24. So the methodology, the 106 subjects were included in ranibizumab biosimilar group and 53 subjects in the Lucentis group. The dosing schedule was ranibizumab biosimilar 0.5 milligrams or Lucentis once every 4 weeks for the treatment period of 24 weeks. Initial double-blind period for 16 weeks, followed by open-label phase till week 24. This is the chronology of the methodology, what we have done in the clinical study. The first week enrolling the patients, then randomizing to one of the two groups, and they received the injections at 0, 4, 8, and 12 weeks. And then at 16 weeks, the assessment of the response was done. Following that, it was an open label, and the study carried out up to the 24 weeks. And the assessment of immunogenicity was done at baseline, week 16 and week 24. And also pharmacokinetic assessment was done in the about 24 subjects. The inclusion criteria of the study was patients with active primary or recurrent subfoveal lesions with classic or occult CNV, secondary to AMD in study group, and male or female patients of age more than 15 years, and the best corrected visual acuity using ETDR charts of 20 by 40 to 20 by 320 Snellen's equivalent in the study eye. The exclusion criteria were the patients who had received a treatment with vetroporphyrin photodynamic therapy in the study eye within 6 months or in a non-study eye within 1 week prior to randomization, or patients who have received a previous external beam radiation therapy or transpupillary thermotherapy or subfoveal focal laser photocoagulation in the study eye, and patients who have received laser photocoagulation either juxtafoveal or extrafoveal in the study eye within 1 month prior to randomization. And the patients who are underwent any surgeries like intraocular surgery, including a cataract surgery, within 2 months in the study eye prior to randomization, or concurrent intraocular condition in the study eye that could require medical or surgical intervention during the study period, or could contribute to loss of at least 2 Snellen's equivalent lines of best corrected visual acuity. Patients who have got an uncontrolled glaucoma, that is intraocular pressure more than 30 millimeters of mercury, despite the treatment with anti-glaucoma medications or history of glaucoma filtering surgery in the study. The patients who are excluded again were the history of idiopathic or autoimmune associated uveitis in either eye, infectious conjunctivitis, keratitis, scleritis, or endophthalmitis in either eye, and history of diabetes mellitus. The results which were analyzed, the primary outcome, that is proportion of patients who lost fewer than 15 letters in visual acuity from baseline to 16 week. In a biosimilar group, it was 98%. In Lucentis, it was 100% at 16 week. And week 24, it was 99% in biosimilar group. And in Lucentis group, it was 100. Since there was no difference, the difference in proportion of patients who lost fewer than 15 letters in visual acuity from baseline to week 16 and week 24 was statistically not significant between the two arms. The secondary outcome, that is proportion of patients who gained at least 15 letters in visual acuity from baseline to week 16. So in biosimilar group, it was 24 in week 16 and 32 in week 24. In Lucentis group, it was week 16 in 32 and in week 24, it was 43. So the difference in proportion of patients who gained at least 15 letters in visual acuity from baseline to week 16 and week 24 was not statistically significant between the two arms. Another secondary outcome, that's the main change in the best corrected visual acuity, that is number of letters from baseline to week 24. From baseline, it was 44, and from day one, it improved to 52 in biosimilar and 53 in Lucentis group. Again, 54 in biosimilar group at week 24 and 56 in Lucentis group at week 24. So the difference in mean number of letters gained from baseline to this group, and one death occurred in an biosimilar group, but no subjects were discontinued from the study due to the treatment emergent adverse events. Immunogenicity assessment was done. All the samples analyzed in the study were negative for anti-ranibizumab biosimilar ranibizumab antibodies and anti-Lucentis antibodies. There were no apparent immunologically mediated safety or efficacy concerns reported in the study. To conclude, ranibizumab biosimilar has comparable efficacy profile to that of innovator ranibizumab based on the efficacy variables. The incidence of adverse events was comparable between two treatment arms, supporting the similarity in the safety profile. The safety profile observed during this study is in line with the known safety profile of ranibizumab. Immunogenicity samples from all subjects were negative for anti-drug antibodies against ranibizumab and no immunogenicity concerns. So, ranibizumab biosimilar may be considered as a viable alternative to innovator ranibizumab in treating neovascular wet age-related macular degeneration. So, these are the references which are used for this study. Thank you, sir.
Beautiful. Thank you, Dr. Rekha.
Yes, sir.
DIA and the spondyloarthropathy and the vasculitis.
Who is here? So, in any case, this study is, after seeing all the slides, quite compelling that it is non-inferior and it's a useful alternative to the innovator. Any comments, Saurabh?
Sir, ma'am's, of course, a proper presentation as such. After we finished her discussion, I have a series of, if you can open your WhatsApp, and this is for Dr. Professor Mohan Rajan and Dr. Natarajan. There is a long list of things that after, I think let's finish Dr. Rekha's discussion, then I'll come to this WhatsApp group that we have along.
Okay. So, Dr. Rekha, did you do any pharmacokinetic study also?
Yes, sir. Pharmacokinetic study was also done in 24 subjects, sir.
Because you...
But not much of drug in the blood was noticed because of only 0.5.
Your results were very magical and, as expected in the sense that non-inferiority in terms of gain, loss, everything. And graphs looked absolutely stereotyped
Similar.
in non-inferiority trials.
Yes.
And but in any case, you see wherever, even though the p-values were not significant, there was always an edge of the yellow bars. Wherever you showed yellow, they were either 5% or 8% higher than this
Yes.
thing. Your comment on that?
Yes,
Sir, Sir Lalitarma sir, I was wanting to comment on that itself. On all the primary and secondary outcomes that you see, there is always a trend towards the innovator molecule being superior, though not statistically significant. And I feel that is purely on the account of a small sample size. If you were to probably
I did notice that, and you are also a sharp observer, I must confess. Same thing you observed. But I wanted Rekha's comment on that. How do you, explain that they are same molecules or similar molecules or whatever? The graph is always, you see, yellow wale, but slightly favorable.
Yes, sir. That was Lucentis group, sir.
Yeah. So today, Dr. Rekha, again the same question. Since you have been involved in this study, you feel enough confidence about its safety, efficacy-wise. Efficacy-wise and safety, you said there's no difference at all. Statistically, p-value, no difference between them. So are you safe that tomorrow you can give in your auntie?
Yes, sir. Because we have given, when we were giving the drug, we were not knowing which drug they have provided. It was double blind. And this is a CSR report of all the centers which they have provided, sir.
Wonderful, wonderful. Now that adds to the confidence with which we are, holding this so-called launch webinar of Vizumab.
Yes,
This gives us confidence.
yes, sir.
Yes, Saurabh.
This is for Professor Rajan, sir. So, Professor
Mohan wanted to make a comment here.
No.
I think it's a fantastic study by Rekha. And one of the 16 centers of that Rani Ruturel group.
Yes, sir. Yes, sir.
Okay, that is very good.
Yes,
I think they've done a very good study, double-blind, active controls, and they have found out the efficacy, safety, everything is almost matching the innovator group, I would say. And
was this study funded by Cipla or Reliance?
Reliance, sir.
Reliance. It is a Reliance study.
Reliance study.
Only the Cipla is quoting.
Dr. Rekha, is it being published?
No, sir. Not yet published.
You are in the process of publishing?
Yeah,
Yes,
you should
sir.
publish that. You see,
Yes, yes,
publication.
Then I think we will have a peer review to question same thing. And I also checked Lalit with the Cipla. I said, how do you rely on Reliance product? They said Reliance makes it, but they have their SOP, their quality
I'm sure
check.
you see, I agree with your question. I've already discussed with the Cipla people. You see, once somebody was talking about Cipla brand, Mohan and all. You see, Cipla's R&D team, I'm sure, I'm confident that they would not attach their name into it till the time their team had visited, their medical branch had visited.
Sir,
And I believe they are not marketing team, Reliance. They are co-producing the drug.
No,
So
sir.
let's come to Saurabh Sinha's question.
Okay.
Just give me around a minute and a half.
Yeah, 2 minutes.
For Professor Natarajan or Professor Mohan Rajan, sir.
Yes.
Both of us, Dr. Rajan and me, wanted that Snehal should come in from Cipla side. So she has texted me here that because this is an open group, she cannot come in and speak. I will quickly read to you what exactly she has written to me right now on WhatsApp.
Yeah.
Sir, and this is very important. From what I understand, they are not doing any quality tests themselves. Chemically, their Cipla is not testing the drug. And I'll repeat what she written for me. Sir, the quality tests are done by Reliance with respect to comparative Lucentis. Cipla does the quality reports, audit of all the reports. They're already auditing the reports. They are not chemically testing the drug themselves. Capillary electrophoresis reports are compared with Lucentis, ELISA tests, again, same thing. All the test reports are strictly audited and only then the batch is taken. Again and again, I asked her again and she said, our quality team gave us the okay in March. That's why they have delayed the launch. Any new batch, it will undergo all tests and Cipla audits. I agree to what they are saying. To what I understand correct, and I hope to be corrected if I'm wrong. They are not Cipla is not chemically testing any of these products. Reliance does the tests and Cipla says go ahead. They have audited the reports. I have severe faith in Cipla. There's no doubt about it. But I have less faith than I have in Reliance, and I hope I'm wrong on that.
No, you're right.
Is Cipla in biological
If it's the other way around, I would have agreed. See,
Yeah,
if Cipla is
Saurabh.
making it and Reliance is marketing,
No,
that would
no,
have been better.
that is what is my.
Absolutely, absolutely, very
One
important.
by one, please, one by one, so that we can hear all of you. Yes, AG.
Yeah, sure.
AG.
Sir,
No, what Lalit?
is
One by
supply
one.
into biologics or not? First question we should ask supply people whether they are into biologics or not, because Intas has a long track record of biologics. They are producing at least.
Let's Nehal WhatsApp to Saurav Sinha. Yes, Nati, you're saying something?
Yes.
No, what I was saying, I forgot. What is that? No. I think the same point as which Saurabh mentioned, that I think we have the faith with the Cipla, but because the Cipla is doing with Reliance, that's why first question is why did you do it? Because Release Seal is the one which they did also with me long time back. Then it was protected in between to a stop for some time, and again they have come back. So they don't have that. Even though the name starts with reliable, it's not reliable still. So I think that is where I think we have to do some extra checks before we promote the Vizumab.
Mohan, your take.
No, I was also a little shocked by that statement because I thought these people were Cipla was into the what do you call the bottom of it, in the bottom of it as far as the quality control is concerned. But if they are going to audit just the reports of the quality control reports of Reliance, I think it's not only for us, for me, but anybody will have doubts about that because somebody else is making the product and you are marketing it. That's all. And there's no way.
Audit is a managerial job.
Absolutely, I think it's a managerial job, and because in the ad board meeting, what the Cipla people were telling is that we are into the quality control totally. So we know exactly what is the molecule, what is the chemical analysis, everything they know. But now they are coming out with the new statements like this.
So is your confidence level going down now after having used?
I'm not sure because already I've used 3 of the pay.
Saurav
Snehal has texted me to answer Avindra's question. Cipla does not manufacture in-house biologics.
Does not manufacture biologics. No.
So that means that means they don't have a lab to check for the quality. They have to outsource it.
I think it's very clear. It is very clear. They don't do any chemical testing themselves.
Such a big company. Why can't they have an R&D? Why can't they have such a big company?
No, sir. Biologics is absolutely a different field, sir.
Different ball game. I know that, but they should.
So for biologics, you need another factory, which is you actually need reactors for E. coli and everything. There are multiple reactors for biologics. To create an reactors for it's something like atomic reactors. So they have to create reactors plus quality control for that.
100% agree with AG.
Hello, sir.
Till the time, yes, who's there?
Yes, sir. This is the Abyss team. 2 minutes videos are playing by the Cipla video.
There is enough time. I think we have time till what time?
10, sir. Only 10 minutes, sir.
10 minutes, so 2 minutes we have. So we will give you 5 minutes. Don't worry.
Okay.
Yes, Saurav.
I think one way out is I just thought because of what Avindra said, what Professor Rajan also said, that and you and Dr. Natarajan had gone to Cipla's manufacturing unit in Goa. I remember you and me had gone to Ahmedabad.
Ahmedabad. I remember.
Intas plant, to see the Intas plant, and we saw the Intas plant ourselves. It was very impressive. That really changed my perspective. What Dr. Professor Rajan said, that you saw yourself, and like Dr. Avindra said, it's a different ball game altogether. Their chromatography, their lab, everything, we saw what they were doing. So if Intas, if Cipla encourages a few people from each center to actually go and see the Reliance production center, and what they actually do, it may give us some confidence.
Wonderful point, Saurav. You have made very nice. You see, I agree. All of us sitting here or listening are for biosimilar, and all of us also want, like Samuel said, cheaper biosimilar. But we have to have the confidence, and the confidence comes for Intas. If Cipla facilitates our visit there, maybe our eyes will open for the benefit of our acceptance rates. So I think with this, let's let that video play. Somebody was telling.
Yes.
Who's going to play that video?
Side AV teams.
AV team is playing or you want me? Yeah. Okay. Can you isko bada kar do? Dikhne do. We can't see the video.
The video is going well. Cannot carry.
So can you exit this?
Sir, one thing is by far sure it's not biologic better what Sawmill has suggested. It's similar, it's not better.
Yeah. Bio better ka Sawmill thoda word thoda wo ho gaya. Because the thing is, we would have been very.
I didn't say it was better, sir. I mean for it to be better in the future. If
Agar ho jata to it would have been a great success for us.
Yeah, I never meant it to say that this is bio better. It is biosimilar, but what is the way forward for that?
Yeah.
Sawmill.
No, I agree.
Yes, sir.
I agree with this. What I'm saying is, it's absolutely good to see nice videos coming out, and you see these are very impressive videos. But till the time this molecule does the job safely and efficacy-wise, then I think all of us are ready to promote it, as long as we are 100% confident of its safety first, as everybody is saying.
Correct.
So
Sawmill, I loved your colorful presentation. You are brilliant. And again, I'm telling publicly, I want you to help me, man, for publishing.
Sure, sir. Sure, sir.
You have to come, man. Now the lockdown is over. You have to come.
Nati, can
I will, sir.
we have some scientific discussion? You see,
This is scientific here. We have data and I want Sawmill to publish it.
Time is only 5 minutes remaining. Sawmill, and you can do some private chat later on. So
he doesn't call me privately. That's my problem.
I will.
Again, you are prolonging. So I see Hemant Murthy here. Hemant, did you hear all this, and can you comment, or you are just a silent spectator? Mute.
No, Abhi, I just joined, yeah, so I could only.
He's come for the next session or what?
Next session.
Next session.
He's come for the next session.
Hemant, you got any experience with biosimilar?
Yes, I do use the biosimilar very. I've been using for a number of years now.
We are talking about Vizumab. We are not talking about Razumab. Razumab to pata hai. Vizumab ki baat kar rahe hain. That is by Cipla.
That is basically manufactured by Reliance.
Yeah.
I've just used it for a case or two, but that's all.
Safe. It is safe.
Any reactions?
No, I didn't see in those patients, but I think it's too early. I wouldn't like to comment on it further. Till I'm quite confident as Razumab. It's not so much for this new.
Also, let me comment. Razumab also went through similar kind of exercise.
Absolutely.
We all had apprehension of Razumab also, and I remember talking about Lucentis favorable than Razumab. But ultimately, as the experience grew, personal as well as nationally, all of us got confident. And today, believe me, we do not distinguish between at center side. AG sitting here, we do not distinguish. In fact, we try to favor Razumab wherever possible.
Correct, because of cost constraints.
Yeah.
I think Visumam also will become like that.
So one comment has come from Sangeet Mittal. He says Vizumab has replaced Razumab for CGHS patients. If you see in the chat box,
Punjab.
Sangeet.
It's in Punjab, sir.
Punjab.
Sangeet.
So in Punjab, the CGHS patients are getting Vizumab now. Earlier, they used to get Razumab. Now they bring the Vizumab injection and we have to use it because it has been provided by CGHS. I have used it.
So what is your experience? What is your experience?
I've used it in 8 to 10 patients and I found no difference as such. But then again, it is very early to comment on that.
So I think with these few words, let's try to conclude this very useful webinar. I think a lot of insights have gone into it. So the confidence will come by mutual sharing. Correct. If Sangeet now has told us, or tomorrow a lot of data comes from, say, Natti, Mohan Rajan, Samuel, AG and Hemant. So if we collate this data, and I will request CIPLA to have one common performer, at least for initial few cases, for our mental satisfaction, whatever, that it is safe. It is safe. That will go, because ultimately we want safe efficacy, and last, as Mohan was saying, cost. Cost is of important consideration, but cannot become the number one consideration.
And also, Lalit, I would like to say that few key people should visit the Reliance factory and find out exactly what is happening there, so that we can get the FIR, that is first-hand information report. Yes.
Nehal must be listening to this, and she will take our message forward. And I think if there's no other point, we should, you see, there's only 1 minute left. Any last comment by Rekha?
No, sir. I thank all these retina stalwarts for sharing this experience. So we have whatever 50 patients who have received this Lucentis and 100 patients in this biosimilar. It was marketed by the Reliance only, sir. Not any major adverse events treatment related happened.
No, even minor are bothering. Even Rekha, major ki baat nahi hai, minor also are worrisome.
Yeah, yes, sir. minor. That's what I told you, sir. One death occurred that was not related. It was only after 2 injections. Then death occurred at home. The relatives told that circumstances told that maybe MI, and that is not related.
Any last comment?
Sir, I think the only thing is the issue that you are talking is doctors should visit the factory. Are we qualified enough to assess these very refined processes?
No. Satisfaction work with their protocols are very good. Not that we will understand too much, but you see, whatever said and done, this Saurav was telling, when we visited Inta's production lab, it does add something. Some kuch addition hoga, minus to kuch nahi hoga.
I will just give one example. I will give an example. A few years back, I visited with the Appasamy factory in Pondicherry. Then only I realized what are the extent of work they are doing and how reliable the quality control is. So unless you have a first-hand information report, you will get definitely convinced. So
I will try to convince CIPLA people. I will try to convince CIPLA people. No, because CIPLA people to take Mohan, Natti, Saurav,
all of us,
all the people,
all the people who are attending this webinar.
In the same flight.
No. I will definitely. This is serious.
I hope not virtual, yeah.
And second point, which all of us should agree, is to work on a common performer and try to share experiences. That will build up confidence. With these few words, please allow me to conclude this.